In fetal life, circulation is designed to bypass the lungs, which are fluid-filled and not yet functioning in gas exchange. 3 shunts make this possible: the ductus venosus, the foramen, ovale, and the ductus arteriosus. Each has a distinct role in directing blood to where it is most needed. Because pulmonary vascular resistance is high, blood is diverted away from the lungs. This promotes right-to-left flow across both the foramen ovale and the ductus arteriosus. The right ventricle carries the greater workload in this system, providing about 2/3 of the combined cardiac output into systemic circulation. After birth, this pattern reverses, but in the fetus, the right ventricle is dominant. Circulation is arranged in parallel rather than in series, meaning both ventricles contribute to systemic blood flow. The system also relies on preferential streaming. Oxygen-rich blood from the placenta travels through the ductus venosus into the inferior vena cava and is directed across the foramen ovale into the left atrium. This ensures that the coronary arteries and cerebral circulation receive the highest oxygen content available. Blood from the upper body, which is less oxygenated, enters the right atrium, passes into the right ventricle, and is directed across the ductus arteriosus to the descending aorta, supplying the lower body and placenta. This selective distribution is critical. It prioritizes oxygen delivery to the heart and brain, the organs with the greatest metabolic demand. Clinically, this explains why disruption of any shunt or abnormal streaming has immediate consequences, and why congenital lesions often depend on maintaining ductal or atrial level patency in the newborn period. At birth, the entire cardiovascular system must reorganize within minutes to support independent life. The most powerful trigger is the first breath. As the lungs inflate, pulmonary vascular resistance falls more than tenfold, and pulmonary blood flow surges. This allows oxygen exchange to finally take place in the alveoli rather than the placenta. Cord clamping removes the low-resistance placental circuit. Systemic vascular resistance rises immediately, creating a higher pressure system on the left side of the heart. This pressure shift is what drives closure of the foramen ovale, usually within the first 1 to 2 hours, as left atrial pressure exceeds right atrial pressure. The ductus arteriosus responds more slowly. Rising oxygen tension and loss of circulating prostaglandins promote constriction. Functional closure typically occurs within the first 2 days, while permanent anatomic sealing requires 2 to 3 weeks. With these transitions, the circulation changes from a parallel design to a series circuit. The right ventricle now delivers blood exclusively to the lungs, and the left ventricle becomes solely responsible for systemic output. Clinically, this transition is critical to understand. Infants with ductal-dependent lesions will decompensate rapidly as the ductus constricts, often presenting with shock or cyanosis in the first days of life. Recognizing this physiology is what allows timely initiation of prostaglandin therapy and stabilization before definitive repair. The ductus arteriosus closes because the balance of constricting and relaxing influences shifts after birth. Oxygen is the main driver. As arterial oxygen tension rises with lung expansion, the ductal smooth muscle constricts. At the same time, the source of prostaglandin E2 is removed when the placenta is clamped, and systemic vascular resistance rises, both favoring closure. Several factors oppose this process. Persistent prostaglandin production, nitric oxide, acidosis, or hypoxia can all relax the ductal muscle. These conditions explain why sick newborns or those with ongoing hypoxemia often have delayed closure. Preterm infants face additional challenges. Their ductal smooth muscle is immature and more sensitive to prostaglandins, which makes the ductus less responsive to oxygen and more likely to remain open. This prolonged patency is clinically significant because it increases the risk for complications such as necrotizing enterocolitis, intraventricular hemorrhage, and bronchopulmonary dysplasia. Understanding these mechanisms helps explain why targeted therapies work. Medications like indomethacin or ibuprofen block prostaglandin production, tipping the balance toward constriction. Conversely, prostaglandin infusion is life-saving in ductal-dependent heart lesions, deliberately keeping the ductus open until surgical intervention is possible. At the bedside, this knowledge guides both closure and maintenance strategies depending on the underlying condition. Basic cardiac assessment in the newborn is about pattern recognition, and each step provides clues to underlying physiology. Measuring four-extremity blood pressures is essential for detecting coarctation. A significant gradient between the upper and lower extremities suggests an obstructive lesion in the aortic arch. Pre- and post-ductal saturations help distinguish cardiac from pulmonary disease. If oxygen saturation in the right hand, which reflects preductal blood, is significantly higher than in the foot, this points toward a right-to-left shunt at the ductal level. Equal saturations that remain low despite oxygen suggest a primary lung problem. Pulse assessment is equally important. Comparing brachial and femoral pulses can reveal diminished femoral flow, again a hallmark of coarctation or other left-sided obstruction. Beyond vitals, the general appearance carries diagnostic weight. Central cyanosis signals inadequate arterial oxygenation, while peripheral cyanosis often reflects poor perfusion. Growth restriction or dysmorphic features may point towards syndromic associations, such as trisomy 21 or DiGeorge syndrome, both linked with congenital heart defects. Perfusion markers round out the assessment. Capillary refill, skin temperature, and mental status reflect systemic blood flow and oxygen delivery. A neonate who is lethargic, cool, and slow to refill capillaries is showing you the physiologic impact of impaired circulation even before blood pressure falls. This systematic approach allows the bedside clinician to distinguish structural heart disease from respiratory illness or sepsis in the critical early hours, ensuring timely diagnosis and intervention. The first heart sound, S1, marks the onset of systole and comes from closure of the mitral and tricuspid valves. The second sound, S2, signals the end of systole as the aortic and pulmonary valves close. Normal physiologic splitting of S2 is an important finding. With inspiration, increased venous return delays pulmonary valve closure, so S2 separates into two components. With expiration, the split narrows again. This respiratory variation is reassuring because it indicates normal right heart adaptation and alignment of the great vessels. A consistently single S2 or absence of splitting raises concern for congenital heart disease. Extra heart sounds such as gallops or clicks are also abnormal and suggest pathology that requires further evaluation. Careful attention to these acoustic patterns helps distinguish normal transitional physiology from structural disease. Recognition of a normally split S2 provides strong reassurance of a structurally intact heart, while deviations from this pattern signal the need for prompt diagnostic assessment. Auscultation in the newborn provides powerful clues to underlying structural disease. A single S2 is never considered normal and suggests abnormal great vessel anatomy, such as transposition or pulmonary atresia, where one semilunar valve does not contribute an audible closure sound. An S3 gallop indicates volume overload. In the neonatal setting, this often reflects congestive heart failure from left to right shunting lesions or severe valvular regurgitation. In contrast, an S4 gallop points toward a stiff ventricle with reduced compliance. Though uncommon in neonates, it may be heard with hypertrophic cardiomyopathy or ischemic injury. Ejection clicks are sharp, high-pitched sounds produced by abnormal semilunar valve motion. Their timing in systole helps localize the lesion. An early systolic click is typical of aortic stenosis, while a later systolic click favors pulmonary stenosis. Fixed splitting of S2, which does not vary with respiration, is highly suggestive of an atrial septal defect, with significant left-to-right shunt. This occurs because equalization of right and left atrial pressures prevents the normal inspiratory variation in pulmonary valve closure. These abnormal sounds are not subtle teaching points, they are bedside warning signs. Recognizing them quickly directs the clinician toward timely echocardiographic evaluation and intervention when needed. The location of a murmur provides one of the most reliable clues to its origin. A murmur heard at the right upper sternal border usually points toward pathology of the aortic valve, either stenosis creating turbulent forward flow or regurgitation producing backflow into the left ventricle. At the left upper sternal border, the focus shifts to the pulmonary valve. Pulmonary stenosis generates a harsh systolic murmur, while pulmonary regurgitation produces a diastolic component as blood flows back into the right ventricle. The left lower sternal border is most often associated with ventricular septal defects or tricuspid regurgitation. VSDS create a harsh hollow systolic murmur as blood is forced from the high-pressure left ventricle into the right. Tricuspid regurgitation, by contrast, results in a hollow systolic murmur that may increase with inspiration. At the cardiac apex, murmurs typically reflect mitral valve disease. Mitral regurgitation produces a blowing systolic murmur, while mitral stenosis generates a diastolic rumble, though stenosis is rare in neonates. Finally, when a murmur radiates to the back or axilla, think about obstructive lesions like coarctation of the aorta or peripheral pulmonary stenosis. These sites are especially important to examine in newborns, since the radiation pattern may be more revealing than the point of maximal intensity. Careful mapping of murmur location helps narrow the differential diagnosis rapidly, guiding both bedside management and the urgency of echocardiographic evaluation. Timing is one of the most critical features when interpreting a murmur in a neonate. A systolic murmur can sometimes be benign, especially if it is soft, vibratory, and not associated with other abnormal findings. However, systolic murmurs that are harsh, loud, or persistent usually signal pathology. A diastolic murmur is always abnormal. Blood should be flowing quietly into the ventricles during diastole, so any sound indicates pathology such as valve regurgitation or stenosis. Continuous murmurs, which extend through both systole and diastole, are also always abnormal. The classic example is a patent ductus arteriosus, where persistent flow between the aorta and pulmonary artery generates a machinery-like sound. A hollow systolic or pansystolic murmur begins with S1 and extends through to S2 without a break. This is always pathologic and most often reflects a ventricular septal defect or significant regurgitation across the mitral or tricuspid valves. Ejection systolic murmurs deserve special attention. They begin after S1, crescendo, and then decrescendo before S2. These can be benign flow murmurs, especially if soft and short, but they can also represent outflow obstruction, such as aortic or pulmonary stenosis. Here, intensity, radiation, and clinical context determine whether the finding is innocent or concerning. By focusing on timing, the examiner quickly separates benign transitional murmurs from those that signal structural disease, ensuring that critical lesions are not overlooked in the newborn period. Certain murmurs have classic patterns that can be recognized at the bedside and should immediately raise suspicion for specific lesions. A ventricular septal defect produces a harsh hollow systolic murmur best heard at the left lower sternal border. The intensity is often disproportionate to the size of the defect, with smaller restrictive VSDs producing louder murmurs because of higher velocity flow. A patent ductus arteriosus generates the well-known continuous machinery murmur, typically heard below the left clavicle with radiation to the back. The continuous nature reflects flow during both systole and diastole, driven by the persistent pressure gradient between the aorta and pulmonary artery. Aortic stenosis produces a harsh systolic ejection murmur that radiates to the neck and carotids, reflecting turbulent flow across the narrowed valve. The quality and radiation of this murmur are important exam clues that separate it from benign flow murmurs. Pulmonary stenosis also presents with a systolic ejection murmur, but this one radiates to the back and axilla, following the direction of pulmonary outflow. An atrial septal defect often presents more subtly. The murmur itself is a soft systolic sound caused by increased flow across the pulmonary valve rather than the defect itself. The more telling finding is fixed splitting of S2, which does not vary with respiration and is highly characteristic of an ASD. Recognizing these patterns is invaluable, as they allow rapid correlation of exam findings with likely pathology and help prioritize further imaging and cardiology consultation. Left to right, shunt physiology follows a simple principle. Blood always moves from areas of higher pressure to lower pressure. In the newborn period, pulmonary vascular resistance is still elevated, so shunting may be limited early on. As resistance falls over the first 6 to 8 weeks, flow across the defect increases and symptoms begin to appear. The receiving chambers of the heart face volume overload. In a ventricular septal defect, the left atrium and left ventricle carry the extra volume because blood that crossed into the right ventricle ultimately returns to the left side. The lungs are also exposed to increased blood flow, which can cause tachypnea, frequent respiratory illness, and poor weight gain. Congestive heart failure develops once compensatory mechanisms such as tachycardia and chamber dilation can no longer keep up with the volume load. Clinically, this is when the infant presents with feeding difficulty, sweating, and hepatomegaly. The long-term risk is Eisenmenger syndrome. With very large and uncorrected shunts, the pulmonary vasculature remodels under chronic high flow and pressure. This leads to fixed pulmonary hypertension and eventually reversal of the shunt to right-to-left flow, producing cyanosis. For the clinician, the key is recognizing that symptoms often emerge weeks after birth, not immediately, and that early detection and intervention prevent progression to irreversible pulmonary vascular disease. Right-to-left shunt. Physiology underlies the cyanotic congenital heart lesions seen in the NICU. Cyanosis is not visible until there is at least 5 grams per deciliter of desaturated hemoglobin in circulation. This explains why an infant with anemia may appear less cyanotic despite profound hypoxemia, while a polycythemic infant shows cyanosis more readily. Clinically, central cyanosis is recognized when arterial saturation drops below about 80 to 85%. There are 2 main pathways to this physiology. In mixing lesions such as transposition of the great arteries, blood from the pulmonary and systemic circuits blends at the atrial, ventricular, or great vessel level, and systemic circulation receives partially saturated blood. In obstructive lesions like pulmonary atresia or severe right ventricular outflow obstruction, pulmonary blood flow is limited, so oxygen uptake never reaches normal levels. The body mounts several compensatory responses. Chronic hypoxemia stimulates erythropoietin, producing polycythemia that improves oxygen carrying capacity but also increases blood viscosity and the risk of stroke or thrombosis. Clubbing develops over time as a marker of long-standing hypoxemia. Metabolic demand rises as the body tries to extract more oxygen, which can place additional strain on cardiac output. At the bedside, these physiologic principles explain why some infants present with dramatic cyanosis despite effective ventilation and why prostaglandin infusion to maintain ductal flow can be life-saving while definitive repair is planned. The hyperoxia test is the classic bedside tool to separate pulmonary from cardiac causes of cyanosis in the newborn. The purpose is straightforward. Determine whether low oxygen saturations are due to poor gas exchange in the lungs or to mixing and shunting at the cardiac level. The method is simple. An arterial blood gas is drawn on room air, then the infant is placed on 100% oxygen for 10 to 15 minutes, and the PaO2 is remeasured. In pulmonary disease, oxygen delivery to the alveoli improves diffusion, and PaO2 typically rises above 150 to 200 millimeters of mercury. In contrast, with cyanotic congenital heart disease, the problem is not alveolar diffusion, but mixing of oxygenated and deoxygenated blood. No matter how much oxygen is delivered, the PaO2 rises only minimally and remains below 150. This poor response is a hallmark of intracardiac or ductal level shunting. The clinical pearl is that cyanotic heart disease shows little to no response to supplemental oxygen. While modern echocardiography often makes the diagnosis more directly, the hyperoxia test remains valuable in critical settings where rapid bedside distinction between lung pathology and structural heart disease determines immediate management. A ventricular septal defect is the most common congenital heart defect, aside from a bicuspid aortic valve. By definition, it is an opening in the septum that allows blood to pass directly between the left and right ventricles. There are several anatomic types. Membranous defects make up about 80%, muscular defects account for 15 to 20%, and inlet or outlet defects are less common. While the location matters surgically, what drives symptoms at the bedside is the size of the defect. Small defects often present only with a loud murmur because the high-velocity jet creates turbulence, but the overall shunt volume is limited. Many of these close spontaneously, with 70 to 80% resolving without intervention. Large defects behave differently. They permit significant left-to-right shunting, which after pulmonary vascular resistance falls at 6 to 8 weeks, can lead to congestive heart failure. Clinical presentation therefore ranges from an asymptomatic infant with a harsh murmur to a baby struggling with tachypnea, feeding difficulty, and poor growth. Recognizing this variability is essential, since timely referral and monitoring prevent progression to pulmonary vascular disease. Small and large ventricular septal defects behave very differently, and knowing the distinction is critical. A small VSD produces a loud, harsh murmur, often grade 3 or 4 out of 6, because of the high-velocity jet of blood through a narrow opening. Despite the striking sound, heart size remains normal and the infant is usually asymptomatic. A large VSD tells the opposite story. As pulmonary vascular resistance falls around 6 to 8 weeks of life, left ventricular pressure is transmitted across the septum, equalizing pressures between the ventricles. This results in significant left-to-right shunting, pulmonary overcirculation, and congestive heart failure early in infancy. The key principle is counterintuitive but high yield. Small defects make loud murmurs, and large defects may sound softer despite being more dangerous. Management depends on size and physiology. Large defects should be closed surgically by 1 year of age to prevent progression to pulmonary vascular disease. Waiting too long risks the development of Eisenmenger syndrome, an irreversible state where pulmonary hypertension causes shunt reversal and cyanosis. Understanding these differences allows early recognition and intervention, ensuring infants with large VSDs receive timely closure before permanent vascular changes occur. An atrial septal defect allows blood to move from the left atrium, where pressure is slightly higher, into the right atrium. This creates right atrial and right ventricular volume overload. The most common type is secundum, accounting for about 70% of cases. Primum defects make up about 20% and are often linked to a cleft mitral valve, while sinus venosus defects, about 10%, are frequently associated with partial anomalous pulmonary venous return. Because the pressure gradient between atria is relatively small, ASDS rarely cause congestive heart failure in infancy. Instead, the hallmark exam finding is a fixed split-second heart sound. The split does not vary with respiration because the right heart is constantly volume-loaded, delaying pulmonary valve closure on every beat. The clinical course is often silent in young infants, but over time, the right ventricle dilates. Management is guided by hemodynamics. Closure is indicated when the shunt ratio, QP to Qs, exceeds 1.5 to 1, and there is evidence of right ventricular enlargement. Understanding this physiology helps explain why ASDS may go unnoticed early, yet still require closure later to prevent arrhythmias, right heart failure, and pulmonary hypertension in older children and adults. The ductus arteriosus normally directs blood away from the lungs in utero, but when it remains open after birth, physiology reverses. With systemic pressure now higher than pulmonary pressure, blood is shunted from the aorta into the pulmonary artery. This steal phenomenon diverts flow away from systemic organs and into the pulmonary circulation. The result is volume overload of the left heart. Extra blood returns from the lungs to the left atrium and ventricle, forcing them to handle increased preload and stroke volume. Over time, this can cause dilation and dysfunction if the shunt is large. Meanwhile, systemic organs experience hypoperfusion. The kidneys, gastrointestinal tract, and even the brain may receive reduced blood flow, which helps explain the association of PDA with complications like necrotizing enterocolitis and intraventricular hemorrhage in preterm infants. Classic exam findings include bounding pulses, a widened pulse pressure, and a hyperdynamic precordium. These signs reflect the runoff of blood from the systemic circulation into the low-resistance pulmonary circuit. The incidence of PDA is tightly linked to maturity. The more premature the infant, the greater the likelihood of persistent ductal patency. This reflects both structural immaturity of the ductal smooth muscle and heightened sensitivity to circulating prostaglandins. Recognizing this physiology is crucial for timely diagnosis and management in the NICU. In the first day of life, a patent ductus arteriosus may be subtle. The only clue can be a soft systolic murmur, as the ductus still behaves like a transitional structure. By 24 to 48 hours, pulmonary vascular resistance falls, flow across the ductus increases, and the continuous murmur becomes apparent. The classic description is a machinery-like sound heard best below the left clavicle with radiation to the back. In preterm infants, the consequences go well beyond the murmur. A persistent ductal shunt contributes to pulmonary overcirculation and impaired systemic blood flow, which is strongly linked to complications such as bronchopulmonary dysplasia, necrotizing enterocolitis, and intraventricular hemorrhage. When the shunt is large, congestive heart failure develops gradually. Over days to weeks, infants show tachypnea, poor feeding, hepatomegaly, and growth failure as the left heart struggles with increasing volume load. Medical management of a patent ductus arteriosus focuses on tipping the balance toward constriction by reducing prostaglandin activity. Indomethacin, a cyclooxygenase inhibitor, decreases prostaglandin E2 production and promotes ductal closure. The success rate ranges from 60 to 90%, with better outcomes in more mature infants. Timing matters. Starting treatment within the first 72 hours of life is most effective before the ductal wall has remodeled and become less responsive. Dosing is weight and age-based, usually 0.1 to 0.3 milligrams per kilogram per dose, given as a series of 3 doses spread over 3 to 7 days. This allows time for progressive constriction while monitoring for side effects. Ibuprofen is an alternative with similar efficacy and less impact on renal perfusion, making it an attractive option in infants at risk for kidney injury. Understanding the mechanism explains why these therapies work. By blocking prostaglandin production, the ductus loses its main relaxation signal and becomes more sensitive to the natural constricting effect of oxygen, allowing closure to proceed. When considering medical closure of a PDA, it is critical to balance potential benefits against contraindications and risks. Indomethacin and ibuprofen, both NSAIDs, reduce prostaglandin levels and promote ductal constriction, but they also limit blood flow to vital organs. Absolute contraindications include significant renal dysfunction, active bleeding, necrotizing enterocolitis, or severe heart failure, where further reduction in perfusion would be dangerous. Even in eligible infants, side effects can include oliguria, decreased renal perfusion, and reduced blood flow to the mesenteric and cerebral circulations. Ibuprofen has advantages. It produces less reduction in organ blood flow compared with indomethacin and is available both orally and intravenously, offering flexibility in administration. Acetaminophen is an emerging alternative. It also inhibits prostaglandin synthesis, but has fewer contraindications than nonsteroidal anti-inflammatory drugs, making it an option when renal function or bleeding risk precludes indomethacin or ibuprofen. One key difference is that only indomethacin has been shown to reduce the risk of intraventricular hemorrhage, a factor that may guide drug choice in extremely preterm infants. Understanding both the contraindications and the nuanced differences between therapies ensures that PDA treatment is tailored to each infant's risk profile and overall stability.